talk that just happened was an excellent prelude to what I'm going to talk to you. So I am going to talk to you about the perspective from which I look at the left ventricular heart devices, the role of the radiologist. Where do I fit in? So we'll get started. First of all, greetings from Iowa. This is my hospital. I will just kind of fill you in. This is the Iowa River. This is our university campus. And this is the main hospital building. I live here on the third floor about 50% of the day. And the outpatient complex in the parking lot. And with that introduction, I hope everybody is awake now post-lunch, and we will go ahead. So as it was pointed out, the number of people needing heart transplant for refractory end-stage heart failure is way more than what is available to us for transplantation. So we had to look for things to let these people survive, and the answer came from the left ventricular assist devices. There was a trial which happened which demonstrated that the left ventricular assist device was a more effective treatment than the optimal medical therapy given to these patients in end-stage heart failure so that they remain eligible for transplantation. This is a busy slide, but this is basically a sort of comparison between heart transplant and the ventricular assist device. Although we are aware that the heart transplantation is the definitive treatment for end-stage cardiac failure, but there are constraints. There are lack of people who can donate these hearts, and there are other problems associated with transplant. So that's where the cardiac assistance systems come in play. They are immediately available. They are a planned intervention. However, there is dependency on the device. As the previous speaker was telling you, that they have to do a very prolonged evaluation to see if the patient is a good candidate or will be able to take the stress, because basically it is carrying a box with you which is pumping your heart, and you can see it ticking. It has batteries. If your battery go out, you can imagine. So this is a nice diagram which is kind of showing what does the patient look like. So this is the heart. This is a device which is implanted surgically into the left ventricle, and then it connects to the aorta, and this is connected with a drive line to the battery pack. This is the controller, and these are the battery packs which sit outside the patient. Patient can now be discharged home. As the previous speaker also said, that earlier we had to hospitalize these patients because we could not send them out, but now we can send them out, and they become outpatients. So this is what a typical person might look like, that this is his heart. He has got the left ventricular assist device in place, and he is carrying his backpack with his battery. So why do we need to put, or when do we need to put left ventricular assist devices? It was initially started only as a bridge to transplantation, but as it was earlier mentioned as well, that now it is also considered a destination therapy. That means the final therapy that they are going to receive for patients who are ineligible for heart transplantation. And it is also considered a bridge to myocardial recovery. We give time for the heart to recover so that we can buy time so that they can go over to the transplantation or other therapies. The type of LVADs available are the ones with pulsatile flow, and the other one is with continuous flow. The one that we use in our hospital is HeartMate 2, which is a continuous flow device. And the pulsatile flow device was one of the, I have never seen one, but this is the one that we use, and it is not synchronized to the heart's rhythm. I was just looking, I really liked this picture, so I thought I'll share it with you, is that the initial devices were this big, as you can see, about 1,200 grams, whereas now the more sophisticated devices are as small as this guy, which is only 25 grams, and this is the device that we use. So when a person has a left ventricular assist device, they need to be evaluated, and so the primary modality by which they are evaluated is echocardiography. So there I do not play a whole lot of role. However, if there is trouble when the system is not working well, at that point in time, sometimes we come in play, and MR is contraindicated in this situation. This is what a chest X-ray of the patient looks like. Its role is little limited because it does not give any functional and not detailed anatomic information. But this is the inflow cannula, which is sitting in the left ventricle, and this is the outflow cannula, and its distal part is radiolucent, and it connects to the aorta. This is the drive line, which connects to the controller and is also connected to the battery packs. And this is the lateral view, again showing the same thing. So when we are given a patient to evaluate with left ventricular assist device, we do an EKG gated MDCT, which tries to capture the heart in frozen state. That means that we try to eliminate the motion artifact by gating. And some of the things that we are looking for is the position of the inflow cannula. The position of the inflow cannula should be in the line of the left ventricular cavity. The interventricular septum should be neutral. That means it should not be deviated towards either side of the ventricle. It should be in the center. And the aortic valve should not be functioning. So think about it. If the blood is being diverted from this device into the aorta, the aortic valve should not open, and that's what we use to gauge. And there should be no aortic valve regurgitation or no significant mitral valve regurgitation. So this is a multiplanar reconstruction of an MDCT of a patient from my hospital. So this is the inflow cannula sitting in the left ventricular cavity, and this is the outflow cannula, which I have shown a little better, which is joining the aorta, and this is a Dacron graft that sits in order to prevent this tubing, to protect this tubing. And this is a double plane multiplanar reconstruction. Basically, I twisted the image in such a way so that I could see the portions of the left ventricular assist device. As you can see, this inflow cannula is in the line of the cavity of the left ventricle. That means it is aligned in the same direction, and that's how we want it. The green arrows demonstrate the interventricular septum, which should be neutral or straight, and here you can see the right ventricle, and this is the outflow cannula connecting with the aorta. This is yet another picture of similar device where you can see the inflow cannula, outflow cannula, and this is a 3D reconstruction of the same device, and it almost gives us real-time anatomical information. This is another 3D reconstruction on a patient where I have taken out the soft tissues, which shows the heart, the left ventricle, outflow cannula, and this is the drive line. And our cardiac surgeons love this kind of reconstruction where we can show them the position of the LVAD in real time. Now coming, as I said, that the role of CT is primarily of a problem-solving modality. It is not the primary modality for investigating LVAD. So there is a host of complications that can occur. I will show you a few of them. So this is one of the complications that can happen is a problem in the inflow or the outflow cannula. Now this is a patient who was having syncopal attacks post-implantation, and if we observe that I said that the inflow cannula should be in the line of the left ventricle. So the alignment of the left ventricle is like the blue line, whereas the alignment of the LVAD is like the purple line. So they are not aligned parallel to each other. So that is why there was inflow tract, outflow tract obstruction. So as you can see that the secondary to this obstruction, the right ventricle has enlarged and the interventricular septum is deviated towards the left side. And subsequently this patient was surgically, the cannula was reimplanted and he is doing well. Now, this is very recent patient who came to our clinic with, he immediately post implantation of the LVAD, he had decreasing hemoglobin and was also running fever. So we interrogated him with a heated cardiac CT, and which demonstrated, as you can see the specks of air. It is so fresh that there is, he was like 2 or 3 days post-op, that there is a fluid collection which is seen anteriorly, and this is the LVAD components which are seen partially. So this fluid collection is hyperdense. You can see that the average HU value of this is 68, which corresponds to blood. So this was diagnosed as a hematoma, and you can also see some changes in the lungs, which are probably because of his post-op status. Now, we did a CT on him 2 weeks later to kind of follow up on what was going on with the situation of his pericardial hemorrhage, and we see that the pericardial hemorrhage has in fact slightly increased, and here you can really nicely appreciate that this is the fat around the heart and this is the ventricle which is being compressed. So he was developing tamponade physiology, a focal tamponade physiology on imaging. So so this collection was eventually drained. Now, this is a nice, if it works, yeah. So this is a nice clip to show you. I will play it again. I will draw your attention to the, okay, it's angry now. So this clip was to show you that the aortic valve does not open in the process. So I will try to play it again, because this is the crux of how we diagnose that the LVAD is working in the right direction. So this is the region of the aortic valve. I would like you to focus your eyes around here. Normally, when the heart is contracting, the aortic valve should open, and we will see what this aortic valve is doing. It's not doing anything, and that's what it is supposed to do when there is a ventricular assist device. So when it is not working for that long, because people can have LVAD for many months, then aortic stenosis is one of the complications that develops. So we have to keep an eye out on those people for aortic stenosis. Infection is a problem. Most of the times it is the driveline infection. It is from the entry site in the anterior abdominal or lower thoracic wall. Imaging is useful only if we can get a focal collection. There are case reports of mediastinitis and mediastinal abscesses, but fortunately we have not encountered many. And so imaging, as I said, has a limited role. Non-thoracic complications can occur where, again, as I said, imaging does not have a lot of role, but here is the list of the non-thoracic complications. Right ventricular failure is one complication that we have seen, develops in about 20 to 30% of the people, and it leads to poorer prognosis of the patient overall, with higher mortality rates, longer stays in the ICU, and problems with bleeding and renal failure, and lower rates of successful bridge to transplantation. So this is one patient where we see that this is the cannula into the aorta. So this patient has got a LVAD in place, and his right ventricle is obviously more dilated than the left side. His interventricular septum is deviated towards the left side. He had signs of right heart failure. Now, I will change gears to total artificial heart. We had our first total artificial heart implanted in earlier this year, and we are very happy to say that our patient is still doing okay, and this is our patient who survived. So this is the only device that eliminates that eliminates symptoms and problems with biventricular heart failure. So basically, in this situation, both ventricles are removed, and they are replaced by the heart valve, the artificial heart, and both the heart valves, all the 4 native heart valves are also replaced. So because of this, the complications of arrhythmia, failing ventricles, and malfunctioning valves are completely eliminated. It can provide blood flow up to 9.5 liters. In a study which was done over 10 years, 65% of the patients were out of the bed by fifth day, and they could walk up to 100 feet. So this is the highest bridge to transplantation which is available. This is a line diagram to show you what the artificial heart looks like. So these are the two chambers which are implanted into the patient, and these are the surgical sites, and these are the drive lines. This is what the x-ray of the patient looks like. I tried to window this image so that you could see there is a lot of air over here, which is, I will just explain to you in a second. So basically it is, there are two pouches of blood which are surrounded by two pouches of air which act as the pumping device. So here you can see this is in systole when the air is expanded and the blood has been squeezed out. And similar, this is a coronal reconstruction demonstrating in systole and in diastole. You can see the blood in the replaced ventricles. And this is a picture showing you the 4 artificial valves that need to be implanted. Now, unfortunately, our patient who had his first artificial heart developed post-op fever, and in spite of a lot of treatment, he was not doing well. So we subjected him to a CT, and which demonstrates that there is a collection around the heart, the artificial heart. And this was his previous CT, which was done immediately post-op, or not immediately, just a week post-op, which shows that the collection which is around the heart has definitely increased. And if you will appreciate, this wall of this collection is enhancing, which indicates that it is inflammatory. So after a lot of difficulty, this patient, we could not control his infection, but he was lucky enough to get a donor heart. So right now he has had his heart transplant. So I'll summarize and my talk and say that the TAH is one of the very new things that is happening, and the longest patient which has been supported with the total artificial heart has lived about 1,000+ days and is still counting. And once stable, the patients of TAH are moved to the top of the transplant list, just like my patient. And I think that